In most cases of nightmares, I'm more likely to use Prazosin or Clonidine because I know that nightmares are due to increased amygdala activity. The amygdala has a high concentration of noradrenergic neurons, therefore I'm more likely to target these neurons through alpha or adrenergic antagonism rather than using cyproheptadine at the first level, because the mechanism of cyproheptadine is not through adrenergic antagonism. The antagonist effect of cyproheptadine at the serotonin autoreceptor, the 5-HT1A, this results in increased serotonin outflow at the midbrain, which results in REM suppression effect, which is very similar to what we see in SSRIs. Now, because cyproheptadine also possesses strong anticholinergic properties, this is linked to reduced REM sleep because cholinergic neurons are active during REM sleep. Cyproheptadine has antihistaminergic properties, which again can result in promotion of non-REM sleep. But one of the side effects that one has to keep in mind is hepatotoxicity. It's a less well-known but severe side effect. Hence, cyproheptadine should not be prescribed in patients with prior liver disease. Amongst other medications that can worsen sleep, we have montelukast, we have beta blockers such as propranolol or metoprolol. They reduce melatonin, therefore can result in nightmares or disturbing dreams. Agents such as pramipexole or levodopa, again because of the dopaminergic potentiation, can result in vivid dreams. Varenicline or Champix, which is a partial agonist of the nicotinic alpha-4 beta-2 receptors, again can result in increased dream recall, abnormal dreams, and dream-related and sleep-related behaviors. Nicotine patches can do a very, very similar thing, abnormal dreams. Cholinesterase inhibitors, on the other hand, galantamine, donepezil, which increases acetylcholine, results in increased lucid dreams, dream recall, sensory vividness, and complexity of dreams. Melatonin, which acts on melatonin receptors, this can be very useful in the reduction of nightmares and, of course, evidence-based in the treatment of RBD. Melatonin may be a good option, alternative to clonazepam in RBD. Let's take medicinal cannabis, Nabilone. Nabilone acts on cannabinoid receptor CB1 and CB2. Nabilone can reduce nightmares in PTSD, but reoccurrence can occur post-cessation. The longer-term safety has not been established as of yet, and one must be cautious about using cannabinoids or medicinal cannabis in individuals with bipolar affective disorder or psychosis. Finally, let's look at the alpha-2 agonists and the alpha-1 antagonist, Prazosin. The alpha-2 agonist, Clonidine or Guanfacine, they produce a reduction of REM sleep and an increase in non-REM sleep. A key point to mention here is that they may actually increase lymphatic system clearance by reducing the noradrenergic tone and hence promotes slow-wave sleep. In fact, in animal studies, dexmedetomidine and Clonidine showed a dramatic clearance of prion protein in prion-infected mice at 5 months post-injection. So Clonidine can be extremely useful in treating nightmares and post-traumatic stress disorder, and doses usually one can start at 50 micrograms, then increase to 100 micrograms. Usual doses are anywhere between 150 to 200. In some cases, these nightmares can cease even at lower doses. Blood pressure needs to be monitored. The disturbed sleep in PTSD has been proposed to involve the alpha-1 receptors, and therefore Prazosin, which is an alpha-1 receptor antagonist, can be used as well to treat nightmares. The doses used, one can start at 1 milligrams, and there is a significant range. The maximum doses of Prazosin that have been used in literature is up to 45 milligrams. Very rarely does one need to go to that dose. One's got to recognize that Prazosin is a shorter acting agent. Usually I will prescribe this at nighttime only. Occasionally, one can prescribe it BD or TDS during the day if the individual has significant hypervigilance or flashbacks, etc., in the context of PTSD to reduce arousal. Prazosin has a lower effect on blood pressure than Clonidine because Prazosin does not have activation of the imidazoline receptors, which reduces blood pressure.